Welcome back to Therapeutics. In this block, we're going to discuss genitourinary conditions. We'll differentiate some of the agents we use for urinary incontinence. We'll also briefly review urinary tract infections and other infections in the GU system, although we will talk about sexually transmitted infections later in the year in another component in men's and women's health. We'll also talk about benign prostatic hyperplasia and how we manage that in older men. We'll talk a bit about male sexual dysfunction as in this block, and we'll reiterate some of the other considerations for this topic in general in men's and women's health as well. Let's now switch gears and talk a bit about genitourinary incontinence. And we see this in men and women much more commonly in older women than we see in men, but we see it in men as well. Very common in nursing home patients as well. And we think of the kind of things you think about for transient incontinence is whether it's drugs or delirium, whether there is urinary retention or restricted mobility, whether their patient is impacted or has an infection or inflammation, or if they have polyuria, could it be, for example, they're on an agent that causes polyuria, like lithium, or have diabetes insipidus, or prostatitis in a man. So there are a number of things that we'll think about with this, and there is a interplay for urinary incontinence that involves both the adrenergic and the muscarinic system. And so we're going to look at augmenting sometimes in urinary incontinence either the muscarinic side of things or the adrenergic side of things to try to address some issues with urinary incontinence. When we think of urinary incontinence, we need to differentiate the types of urinary incontinence, how they present, and whether or not there is a drug cause for it. So before we add drug therapy or intervene, sometimes the issue is to look at taking drugs away. So let's first look at urge or overactive bladder. Typically in this situation, we often want to look at agents that are muscarinic in nature that stimulate the bladder, such as bethanechol. We also look at stress incontinence, which we will see alpha blockers such as prazosin sometimes will affect urethral sphincter tone, so that could be avoided by avoiding those. Overflow incontinence, we sometimes see anti-muscarinic agents, or sometimes even calcium channel blockers, or even opioids affecting things there, and so we want to look at stopping those therapies. Functional incontinence sometimes is a function of sedating or confusion. Also, we could see excessive diuretics that, let's say, for example, this is very common in many older folks for whom they're on diuretic, and then their ability to get to the toilet in time, within an hour of taking the diuretic is limited, and as such they become incontinent. Well, the issue is not to do anything other than to reconfigure the way they get their diuretic, and there are opportunities to get toileted. And sometimes it's a sort of a mixed pattern of more than one function here. But the first issue we think of before we add on interventions is to look at whether there's a common etiology that can be changed or a drug cause that can be eliminated. The non-pharmacologic interventions for urinary incontinence for all patients look at exercise and weight loss. Typically, in many cases, can really help for patients who have enlarged BMIs. Excessive weight contributes to part of the problem. For stress urinary incontinence, probably the most common thing you'll see are Kegel exercises to expand the pelvic floor. Also sometimes biofeedback. Sometimes we'll see a need for surgical repair, although that's sort of secondary. And or sometimes there are other things that can be used mechanically or as part of devices that are associated with stress incontinence. In fact, there are just to market in the last couple of years marketed directly to patients, really products that are very helpful and allow folks to just manage their stress incontinence if it's mild to moderate in a way that's really dignified for them, and they can go about their normal daily life without a problem. For urge incontinence, sometimes pelvic floor exercises with some addition of some meds, we'll talk about those, or bladder training sometimes is helpful, or other types of modalities that a urologist may look at. For folks who have dementia, we look at schedule and timing their voiding. Particularly that's true if they're on diuretics as well. On overflow incontinence, we want to look at either self-catheterization if that's appropriate, or if it's an enlarged prostate for a man, can you do something to reduce the size of the prostate that's contributing to the problem? So let's now look at some of the drug modalities we look at for treating different types of incontinence. Typically for urge or overactive bladder, the most common agents we'll see used are the antimuscarinics or anticholinergic drugs. There are a number of them on the market, and they offer some benefit here. Now, the thing we have to think about with overactive bladder is that while these agents improve symptoms, the antimuscarinics themselves can cause some other problems. For example, in a man with an enlarged prostate would worry that this could actually affect urine streams. So we need to sort of balance the pro and the con of that. The other agents that can be used for urge incontinence include sometimes a beta agonist, not very commonly used, or one of the other injectable agents, but really the antimuscarinics are the first-line therapy almost always. And usually for urinary incontinence, it really helps when they have a full evaluation by the urologist. So most of the time, these antimuscarinics are going to get started by a urologist, but you're going to be dealing with these patients who are on these agents that are originally prescribed by the urologist. For stress incontinence, the first issues are to look at particularly if it's mild to moderate, to look at pelvic exercises, to look at maybe some modalities or mechanical devices or products that can assist with that before we look at drug therapy. There is a role sometimes for alpha-adrenergic agonists like pseudoephedrine or phenylephrine, topical estrogens, particularly if vaginal estrogens, if there's an issue of severe stress incontinence in a peri- or postmenopausal woman. There's also some role of using duloxetine, not an FDA-approved use, but if there's another indication for it, this may have some added benefit there. For overflow incontinence, the alpha-adrenergic antagonists are a consideration. Terazosin, we'll see this very commonly in men with enlarged prostates. And so terazosin is probably, or Flomax is probably the agent we'll see most often. The thing you have to worry about these agents is hypotension, particularly if you're giving it to a man who's getting up frequently at night to pee and he takes his dose at bedtime. Well, if he gets up to pee in an hour or two, he could get significantly orthostatic and fall. So we need to worry about that. For overflow incontinence with an enlarged prostate, we sometimes use a 5-alpha reductase inhibitor like finasteride. We talked about that to slow the progression or enlargement of the prostate. Those take months to work. They're not going to work right away. And on rare occasions, we'll actually use a cholinergic drug like bethanechol. But that's pretty much because we worry about some other side effects of cholinergic systems, and it's a drug that binds to many receptors in many places. Bethanechol would really be a second-line agent. Finally, in overflow incontinence, a relatively new indication are the phosphodiesterase inhibitors that are now approved for BPH, particularly tadalafil is indicated for that purpose as well. So if you have a man who has both prostate enlargement with urinary overflow incontinence in combination, enlarged BPH, prostate, in combination with sexual dysfunction, for example, erectile dysfunction particularly, then that may make sense. For functional urinary incontinence, there's no real direct treatment. Here's the issue, though, is that you want to look at evaluating their opportunities for toileting, particularly coordinating that with the time, for example, of diuretics. And then for mixed focuses, you're going to look at individual treatments for individual components. But again, in those circumstances, particularly almost all these circumstances, they're probably going to have a urology evaluation. But you as a clinician, no matter where you're practicing, are going to see folks who are on these therapies, and need to have a heads up of when they need to go back and see the urologist or how these therapies interplay with other conditions they may have. When we consider some of the antimuscarinic agents, particularly associated with a lot of dry mouth and constipation and dizziness, as you'd expect, sort of here's the pattern of the agents of what you'd expect to see. And interestingly, is if you need to use one of these agents, you can sort of map which agents are associated with lower symptoms in patients if they need one of them. And for example, the oxybutynin gel, which is certainly a more expensive specialty product, but if they're having a problem with dry mouth or constipation, less likely to see that also, as well as one of the oxybutynin TDS products. Let's look now at benign prostatic hypertrophy, which is pretty common in men over the age of 60. About half of men at age 60 will have some BPH, and by 85 would expect that almost every man will have it. And the pathophysiology and clinical presentation, it really relates to testosterone, long-term testosterone exposure, contributing to an enlarged prostate. And you may see the type of symptoms that present lower urinary tract symptoms that are seen in a number of men, including decreased force or hesitancy or dribbling on initiation of urine streams, or they may have some degree of urinary urgency or frequency. Many times we look at multiple times in the night, for example, getting up to pee. The American Urology Association has a symptom index scale of 7 questions, and let's look at those in just the next slide. So here are the questions that are typically looked at, and then we look at the frequency of each of these elements. Does a patient have a sense that they don't empty their bladder? How often do they need to urinate in a 2-hour period? How often have they stopped or started several times while urinating? Have they had difficulty postponing urination? Do they have a weak urine stream? Do they have to strain to start urinating? And how many times do they get up in the night to pee? So based on how an individual will respond to each of these questions, helps you to target to what degree they are more significant symptoms, and then looking at modalities to manage that. Now again, while these are going to be managed primarily by a urologist, you could look at this type of screening assessment done in primary care and then make a determination about whether or not they should also get a referral to the urologist as well. For managing someone with BPH, first of all, the evaluation typically looks at a medical history, a digital rectal exam, and renal function urinalysis. If you suspect prostate cancer, maybe a PSA, there's been a lot of debate about getting a PSA or not getting a PSA over the last decade, partly because it's fairly nonspecific, and so I'll defer to the clinical medicine folks and your urology folks to indicate what the current thinking is about getting a PSA or not. The difficulty, though, historically with getting a PSA has been that you get a number that patients really hold on to that number, and you don't really know what to do with that number. If it's elevated, it may be part of norm, or it may not be. If it goes up, you need further workups, and then how many times do you have to get workups for the number of times where it's really a meaningful problem? You want to look at also evaluating patients who have urinary retention, and if their post-void residual is greater than 50 milliliters, they are at increased risk for infection. So that might be something you can do with an ultrasound or get that evaluated by the urology team. And then looking at meds that can actually make BPH symptoms worse. So the alpha-adrenergic agonists or decongestants, the antimuscarinics are notorious for this. Diuretics can also contribute to the problem. And we can also see with testosterone replacement that actually stimulates prostate growth. So all of these are important. If their AU-ASI score is less than 7, that's usually indicative of moderate weighting. For those with scores of 20 and up, usually they should be really seen by a urologist, but even scores above 8, probably you'd want to defer those folks. Hey, why don't you get an evaluation by the urologist to evaluate appropriate intervention? When we look at treating BPH, probably the most common of agents we initially see started on folks are one of the alpha adrenergic blockers. Most commonly, we'll see terazosin, but you could use one of the other agents, tamsulosin, excuse me. You see it's more uroselective. So tamsulosin or Flomax is an agent of choice because it is associated with a little less hypotension, orthostatic hypotension, than some of the older agents are. So tamsulosin is probably the agent we'll see used most often. The older non-specific agents like digoxin or terazosin are usually avoided because of this hypotension, particularly first dose. And you worry about a patient getting up out of bed to pee and then hitting the ground and breaking a hip or something like that. So we really worry about that. You also want to look at before and after scores. You'd expect that their score is going to go down by 4 to 6 points if it's effective. And if it hasn't, then you have to reevaluate. Does it make sense? You also have to worry about cytochrome P450-3A4 interactions with these. And there has historically been a concern for intraoperative floppy iris syndrome with alpha blockers. So for cataract surgery patients, usually the ophthalmologist will evaluate this prior to going to surgery, but this is a concern for folks on these agents if they're going in for cataract surgery. You may want to postpone starting therapy or look at stopping therapy before and around time of cataract surgery. The alpha reductase inhibitors, there are a few of them. Finasteride is the one we typically think of on the market, and these are usually reserved for men who have a lot of symptoms. They only work after about 6 months or so by slowing the growth of the prostate gland or actually even shrinking it over time. But the benefit, you won't see anything for the first 6 months or so, and then what you typically will see is a modest effect at all. So these are really considered, and many times, second-line agents, not first-line agents, but usually in the domain of the urologist, not in primary care. The phosphodiesterase inhibitors are making a role, particularly tadalafil, which is indicated now for it. So if you've got someone who is also on, who has erectile dysfunction, then this may make sense. But what you need to avoid is we don't give a phosphodiesterase inhibitor with any of the alpha agents because that's excessive hypotension. So you pick one or the other. Either you pick an alpha blocker or you pick a phosphodiesterase inhibitor, typically not both. Now, there is a role for combined therapy. Usually what you'll see is finasteride plus one of these other vasodilating agents, but not typically two vasodilators. There are a couple of supplements that have historically been used. One is soft palmetto, and there's conflicting evidence about how effective it is. The urology societies pretty much have sort of indicated that they don't really see a lot of great data for it, so don't usually recommend it. And then there's some benefits for other agents, some other supplements that have a beta cytosterol component to them. I don't have any experience with that, and I would defer that to urology to kind of make an assessment. There is some role perhaps for surgery with severe symptoms, but the problems with surgery is that it could lead ultimately to impotency or other problems. The techniques and the procedures have gotten better over the years. And then almost counterintuitively, there is a role for antimuscarinic therapies, but these are done typically when you're looking at the symptoms of BPH being primarily similar to urinary urgency or hyperactive bladder. And so that's really probably going to be done by the urologist using antimuscarinics. And they have a role, and I see a fair number of patients who come into the hospital with enlarged prostates, men who come in on an anticholinergic drug. And we're really hoping that the evaluation is then appropriately done to look at basically the component is pretty much limited to an irritative symptom of urinary urgency or frequency, and not so much initiating streams or some other symptoms for which antimuscarinics make things worse. Here are some of the agents we've sort of looked at. The first are trazocin, doxazocin. Largely don't use them because of orthostatic hypotension. Tamsulosin may cause orthostasis, but it's probably considered the drug of choice. Typically, any of these alpha agents are going to start at bedtime, and watch out particularly for a first dose hypotensive effect. Some of the other agents, let me go down to the on the list a bit, is finasteride is used. Don't expect an effect for the first 6 months or so. And it will reduce the size of the prostate over time. It's really considered almost a add-on therapy, not a first-line therapy. And tadalafil is making its role. We'd avoid it with an alpha blocker, one or another. And the data, it hasn't been used. We haven't had as much clinical experience with that for over the years, but it is, I think, beginning to make a lot of sense for a patient who has concurrent erectile dysfunction associated with their BPH. We'll also look at talking about treatment of urinary tract infections, and this is a very common bacterial infection, particularly in women, and it accounts for, in office practice, outpatients, lots of office visits per year, and many hospitalizations as well. Under the age of 50 years, it's predominantly women. Over the age of 50, still more women than men, but men are more likely to have a problem with prostate as well. And for women, we're going to talk about complicated versus uncomplicated urinary tract infections. You know, is it limited to the bladder? Is it just cystitis? Or is it a more rip-roaring urinary tract infection or a complicated urinary tract infection for which we're worried about pyelonephritis, infection sort of in the kidney and maybe even systemically? Those are more aggressively managed. And in men, any urinary tract infection in a man is considered more complicated, and so we would treat it in a man a little more aggressively, only because men have longer urethras than women do. Women, it's, you know, the shorter urethra means it's more likely that that's going to be contaminated, and if it's community acquired and if it's limited to bladder infection, most often, particularly in women, that urinary tract infection is most commonly going to be E. coli, but it could be other things as well. We'll talk about that in a bit. Predisposing factors to a urinary tract infection include age, female status, diabetes. Why diabetes? Diabetics, particularly in poor control, are going to have more glucose spill into urine, and glucose in the urine is a risk factor for, you know, a nutrient for bacterial growth. On top of many folks, particularly with poorly controlled diabetes, might have some modest immunocompromised status as well. Pregnancy also risk factor. Immunosuppression is anything that's to do with urinary tract instrumentation. So we avoid, and you will hear this once you get in clinical practice, particularly in the hospitals, we try not to use Foley catheters if we don't need them. If we need them, we try to get them out as soon as we can. There's a huge campaign over the last decade in hospitals to get Foley catheters out because they are just a UTI waiting to happen. We also worry about urinary tract obstruction as a risk for a predisposing factor for UTI, pre-existing renal disease, renal transplant, or anybody who has neurologic dysfunction, that particularly if that neurologic dysfunction is correlated with frequency or ability to empty their bladder. So those are all factors that predispose to the risk for UTIs. We alluded to this earlier, but in community-acquired urinary tract infections, the most common pathogen you're likely to see, particularly in women, but in men too, is E. coli. And the issue with E. coli in particular is that the likely source of E. coli usually is the GI tract. And one of the common things that should be particularly if you're working in family medicine practice, particularly in women and adolescent women, girls, they should probably learn the appropriate hygiene about when they wipe after urination, wiping from front to back and not back to front. And the reason for that, kind of obviously, is that you don't want to cross-contaminate any potential fecal organisms up to the urethra that could contribute to a urinary tract infection, particularly E. coli. Nosocomial or healthcare-associated urinary tract infections are more widespread types of pathogens that are involved. E. coli is still about a third, perhaps, of what you'd see for pathogens. A lot of other gram-negatives are listed here. Pseudomonas aeruginosa becomes more problematic. And fungal infections pretty common as well. And what the other thing that will differentiate for urinary tract infections is whether these organisms are colonization or infection. And so we don't typically treat pure colonization in the absence of signs of infection because we may never, particularly in somebody who has instrumentation of their bladder or some other predisposing risk for ongoing colonization in their bladder of these things, even though we expect the bladder contents to be sterile, we may never eradicate the organism. So if they're not infected, we may elect not to treat it. And so in clinical practice, you'll find differentiating treatment of colonization of a positive urine culture versus when somebody is truly infected. The clinical presentation of urinary tract infections, the simplest is just a simple bladder infection. These are lower or considered uncomplicated UTI. Typically, women, not men. They'll often have pain on urination, frequent urination, a sense of urgency. Occasionally, you may see foul-smelling urine or gross hematuria, but that in itself is not, it doesn't have to be present for a cystitis to be there. And the foul-smelling urine doesn't itself also mean that they have a cystitis, that the foul-smelling urine could be a metabolite of something they ingested. For example, asparagus-smelling urine, we've already briefly talked about that this summer, is that's the metabolite of asparaglucic acid. Well, maybe there was something else in their diet that contributed to that foul smell, and it's not necessarily bacterial infection. Keep in mind also that in older patients, the first sign of a urinary tract infection could be a change in mental status. So that's always a concern. Pyelonephritis or upper urinary tract infection by its very nature is always complicated. And we see some of the same symptoms we see with cystitis, but they may present with suprapubic pain, costovertebral angle tenderness, flank pain, fevers, chills, white count elevated, sometimes presents also with nausea and vomiting. Factors of a complicated urinary tract infection, any male who has a urinary tract infection, that's automatically considered complicated. Also, hospital-acquired in pregnancy, if there's any anatomical urinary tract abnormality that's present in childhood, urinary tract infections are not expected, so we'd consider those complicated. If folks have had recent antimicrobial use, that indicates we have likely changes in flora. Folks who have diabetes also will have a predisposing risk factor to more complicated UTIs because, particularly if their diabetes is not in good control, glucose in the urine. Indwelling catheters are problematic. Recurrent urinary tract instrumentation, if they've had to be, for example, straight cath frequently, or they have a history of catheterization, or immunosuppression. All of those sort of factors are related to the risk for a more complicated urinary tract infection. We also can see recurrent cystitis, and this is more common in women who have sort of recurrent infections. They have infection after infection. And one of the things we need to differentiate is this relapse or is this reinfection. Relapse refers to the same organism. We didn't really wipe it out the first time around. It's the same organism. It's within 14 days of discontinuing antibiotic. And what we then look at, we sort of look at, well, did we pick the wrong antibiotic or did we use the right antibiotic, but we didn't give it for a long enough period of time? And we differentiate that from a reinfection, which is a different organism. Basically, maybe they got cured from their prior or treated well and they resolved their first urinary tract infection. Lo and behold, they have a new UTI with a different organism. Now, it might be the same group. It might be another E. coli infection, but maybe it's a different E. coli DNA sequenced E. coli than what they had as their first speciated E. coli urinary tract infection. Diagnosing a UTI, we're looking at, in addition to bacteria in the urine, we're looking at white cells in the urine, maybe red cells, cloudiness, nitrite positive, and leukocyte esterase positive. And if it's pyelonephritis, you may see CAS. And in about 1 out of 5 patients, they may also have positive blood cultures, particularly with a complicated or pyelonephritis UTI situation. Keep in mind, though, that and again, ask, as you're working through cases, you're working through clinically adapting and thinking about when do I treat, when don't treat a UTI. Keep in mind of how we're going to differentiate and sort of learn from your colleagues and your instructors about differentiating colonization and when we're going to treat that versus a full-blown urinary tract infection where it manages treatment. And one of the issues here is they might have bacteria in the urine. The question is that colonization or is that something we need to treat? Well, if they're mounting other signs of infection, they've got an elevated white count in their urine, they're positive for nitrite as well as leukocyte esterase, and they're mounting a fever or other symptoms, then that's an indicative of treatment as opposed to just a colonization where you're seeing a positive urine culture. And other clinicians will share with you, unless you have a suspicion for an infection that you would ultimately consider treating, don't get a urine culture when you don't have a plan that you would ever consider treating or doing something with that urine culture results in the first place. Our treatment of urinary tract infections depends on what we've got. The common empiric treatments to start with are listed here, and then we're going to adjust that based on the culture sensitivity that comes back. So these listed on this slide are empiric treatments for different types of urinary tract infections, but urinalysis is almost always going to be done before you start therapy on these folks, and you may very well, and it probably is appropriate in almost all cases, to change your antibiotic to a narrower spectrum agent or a more appropriate agent based on your culture sensitivity results if that's warranted based on how they're responding to your drug therapy. So for uncomplicated cystitis, you really want to cover most often is E. coli. And what will cover E. coli reasonably well is Bactrim, trimethoprim, sulfamethoxazole for 3 days. Now, when are we going to avoid that? If somebody has a sulfamethoxazole allergy, we're going to avoid that. If the community resistance with E. coli is significantly higher, we're going to avoid that. If there are interactions with Bactrim, for example, somebody's on Coumadin or warfarin, then you may consider, hey, maybe I want to consider something different. Or if I am going to continue it, I've got to manage that interaction with the warfarin by getting another INR, maybe decreasing the Coumadin dose, and following accordingly. Another treatment of choice is a 5-day course of nitrofurantoin. We're going to limit, though, nitrofurantoin makes sense for a younger patient, younger woman with uncomplicated cystitis who has good renal function overall. If someone is older, particularly if they're older with renal compromised status or even younger with renal compromised status, nitrofurantoin actually won't work because you won't secrete enough nitrofurantoin in the urine if their creatinine clearance is below 50 or 60 mils per minute for it to be effective. So you want to just go in with these both first-line empiric treatments of either trimethoprim sulfamethoxazole for 3 days or nitrofurantoin for 5 days. You want to keep in mind that that makes sense for the patient who's in front of me. A third alternative is phosphomycin, and the reason on this slide I've graded out, even though it's a single dose, it's quite expensive, and so many clinicians won't pick that, partly because either insurance won't cover it without a prior authorization, or if the patient would still have a very large copay, or if insurance covers or the patient out of pocket, it might be prohibitive for them. Some of the alternatives are considering beta-lactams for 3 to 7 days for uncomplicated cystitis. Maybe something like cephalexin, for example, might work, or a fluoroquinolone for 3 days. But keep in mind the quinolones like Levaquin or ciprofloxacin and Cipro is cheap, but because of adverse effects and the risk for being a pretty broad spectrum agent with the risk for future resistance, the FDA and the CDC often recommend avoiding it if other alternatives will work. For outpatient management of uncomplicated pyelonephritis, you can go with Bactrim or fluoroquinolone again, or a beta-lactam, but they're a little less effective, but for a much longer duration. So you're looking at 2 weeks of therapy for Bactrim, or a 5 to 7 day therapy for quinolone. And then for complicated UTIs, usually we will start therapy as an inpatient, and you could generally look at, in practice, we either see a fluoroquinolone for 5 days or an extended spectrum beta-lactam for 5 to 14 days. Aminoglycosides can make sense. The problem with aminoglycosides, and maybe I'd almost say put that in a bracket, is while it's in most of the guidelines, aminoglycosides, gentamicin and tobramycin, because of their risk for nephrotoxicity and ototoxicity that can be permanent, we often limit those to situations where other therapies are not going to work. And UTIs in patients who are pregnant, there are a number of regimens, and typically what's going to make the most sense is to use a beta-lactam, like either amoxicillin or cephalexin, if that makes sense. And or maybe nitrofurantoin if renal function is good, although we'll avoid that after week 38 or if a patient is close to or in potential labor. The things we want to avoid in pregnancy are those that we know are teratogenic or are problematic agents. And so those include the fluoroquinolones, the tetracyclines, Bactrim, particularly later in pregnancy, and the aminoglycosides. The aminoglycosides might not be so terrible in that they don't cross the placenta all that well, but they are still associated with oto and nephrotoxicity, and for lots of reasons, many clinicians look at avoiding those. So typically, a beta-lactam, when you need to treat a UTI, makes sense. The other issue is to differentiate colonization from true infection. That may help guide your treatment modalities, although even colonization in a woman who's pregnant, that itself may be higher risk. And so you're going to find that clinicians will usually err on the side of treating a UTI in pregnancy and trying to treat it with an agent that's considered safer, like a beta-lactam. Catheter-related UTIs are instrumented UTIs, and short-term indwelling cath, like a Foley, the risk of UTI goes up every day. So for every day that catheterized, 5% increase in the UTI, and by day 30, it's almost inevitable that patients will have bacteriuria. So hence all of our discussion, and what you'll hear much more about is avoiding Foley catheters in patients unless you need them. And not only are they going to be colonized or have bacteria in the urine, may be infected, but the likelihood that that's going to be multi-drug resistant goes up as well. And so typically if they have a catheter-related UTI, we're going to treat it if it's symptomatic as opposed to if it's just colonization. And for long indwelling catheters, expect that they will have colonization and only treat if they're symptomatic. Also get that catheter out and replace it with a new one. And try to limit therapy to under a week because of the risk for sort of predisposing to multi-drug resistant pathogens in the future. For prostatitis, typically the patient may be asymptomatic or may have urethritis. Typically, we're going to worry about trichomoniasis or Neisseria gonorrhea or E. coli, and our duration of therapy is, in this case, up to a month. And typically, it depends on the organism. For gonorrhea, we're going to give ceftriaxone IM and then a continued therapy with a quinolone. Typically, ciprofloxacin is the agent we'll see. Sometimes Bactrim is used as well. In these modalities, so a single dose of ceftriaxone followed up with a month's worth, typically, of ciprofloxacin is what we usually see in practice. For chronic bacterial prostatitis, symptoms have been in place for at least 6 months. Again, we're going to look at a 28-day course, usually of ciprofloxacin. Sometimes, depending on what we're seeing, might see minocycline or doxycycline or Bactrim used. as well. But more commonly, I think we see ciprofloxacin as probably the agent we will often go to. For epididymitis, initially we'll see as it related to gonococcal or chlamydial infection, ceftriaxone plus doxycycline is typically what's used. If there's a question of enteric organism, levaquin, if it's not gonorrhea, is typically going to be used for up to a week. So in sexually transmitted infection, men's health, and GU interventions, here are some of the drugs we'd expect you to have some familiarity with dosing.